will be my pleasure to introduce my colleague, Dr. Azza Maktabi, for the ground today. It will be about the Retinoblastoma Mimickers. I will give you a brief about Dr. Azza. Most of you know about hair, but for those who are outside Kekish or from elsewhere, they can know hair. Dr. Azza completed her bachelor degree in King Saud University in 1991. Then she completed her residency combined program at Combined KSU Saudi for 2000. Then 2004, she had 1 year fellowship in uveitis and pathology at Kekish. Then in 2008, she joined Wills Eye Hospital, and she had 1 year fellowship with Shields in ocular oncology. Then in 2009, she had 1 year fellowship in ocular pathology with Professor Raf Eagle in Wills Eye Hospital. Then she joined multiple hospitals, King Salman Hospital in Riyadh, King Khalid Hospital, Kharij al-Yamama Hospital. Then the last journey for her was 2013, where she joined Kekish as a consultant pathologist and ocular oncologist. And she is a very active member in Saudi Ocular Oncology Society, the small new group. And she had multiple presentations and publications in the field of ophthalmology and pathology. It will be my pleasure to introduce her. And as you know, the retinoblastoma will be faced by you as a general ophthalmologist or other than ocular oncologist, and the case will be arrived or landed in ocular oncology clinic at the last journey. So it's the most important point is to catch the case early and diagnose the case early. That's why the topic, I think, is very attractive for all ophthalmologists, and all of us should master the retinoblastoma diagnosis and exclude the mimickers. Welcome, Dr. Azza.
Thank you, Dr. Said, for this introduction. I would like to thank you for accepting moderating this space, taking into consideration your strong background as a retina consultant and as an ocular oncologist trained with the Shields as well. So I meant of this lecture to alert the residents about the mimickers of retinoblastoma. As Dr. Saad mentioned, you will face it in your clinic. You may be in a remote area. So it's very important not to miss an RB case. It's good to miss a case of codes, for example, and send it as an RB, but it's very drastic and to miss a case of RB and treat it as a Coats disease. So I always ask patients when they are coming from referral hospitals and they were diagnosed with other things than retinoblastoma, but retinoblastoma was raised and then referred for KKH for workup and the diagnosis of retinoblastoma, and turned out not to be retinoblastoma. I always encourage the patient to go and thank the ophthalmologist who examined this patient and referred him, because this is really life-saving. So I would like to start my talk today. And of course I had to, this is a recent photo of Dr. Misfir from the National Day. So I would like to thank him for all his efforts in taking care of retinoblastoma patients in all the kingdom. And each of us have learned from him about retinoblastoma, and I hope that he will continue this national mission, as he mentioned. I would like also to thank all my colleagues from KKH and from outside KKH who referred the cases to us for workup, and all the residents that helped me with putting up this lecture. So just as an introduction, everybody knows that retinoblastoma is a true successful story. So it is an uncommon intraocular tumor, though it is the commonest intraocular tumor in children. And the incidence is 1 in 15,000. So there's no sexual or racial predilection, and the median age at presentation is 15 months. This differs if it's unilateral or bilateral. And there's no, almost half of them are unilateral and half of them are bilateral. Most of the cases, up to 90%, they are diagnosed under the age of 3. So it's a childhood, as I mentioned, intraocular tumor. Clinically, it's variable, depending on the classification and the presentation. It might be presented as early especially when we do a family screening. It is a small, it appears clinically as a small transparent lesion in the sensory retina that may be easily overlooked. And this slide is important because this gives us an idea why we misdiagnose mimickers of the retinoblastoma, because retinoblastoma is a variable, it's wide range. It might, these small lesions might enlarge and it becomes opaque and white. And then they develop dilated retinal vessels. When they get even grow larger, they tend to seed, and also they cause secondary retinal detachment, and 15% of the cases might present with neovascular glaucoma as well. So for those who are dealing with glaucoma, keep this in your mind, please. So this is the commonest slides used to show the international classification of retinoblastoma. And as you know, we have class A, B, C, D, and E, where A is the small, less than 3 millimeter and away from the macula and the disc, and then the E is the non-salvageable and end-stage retinoblastoma. And this is important because each of the classification will have a different management. So the most commonest presentation is leukocoria. This is from our registry, and as you can see, we have we studied 1,033 from the registry, and up to 775% they presented with leukocoria, followed with strabismus, and this is in concurrence with the international studies. Different modalities of treatment are offered to the patient, and this also depends on the classification, as I mentioned earlier. So we have a focal in terms of laser therapy and cryotherapy. We have a chemotherapy, and chemotherapy could be local as intravitreal or intracameral chemotherapy. We usually use melphalan and topotecan. Also, the chemotherapy is in the form of systemic chemotherapy. We can give a single dose of IV carboplatin. We can give systemic 6-cycle triple agent chemotherapy as chemoreduction or as adjuvant chemotherapy after inoculation for high-risk factors. Thanks God, in 2018, we introduced the intra-arterial chemotherapy in collaboration with King Faisal Specialist Hospital, and we have good numbers so far with good success. Radiation-based therapy, which is external beam radiation, used to be, before the era of chemoreduction, the mainstay treatment for advanced retinoblastoma. But thanks God, with the introduction of chemotherapy, it is the last option of treatment. And recently also it's substituted with a local radiation with a plaque therapy in case that the chemotherapy failed. And the last option is inoculation, but this is a life-saving procedure in advanced retinoblastoma. And unfortunately, our registry showed that usually we have an advanced and late presentation in our patient. So we start talking about a little bit about topic, and I would like to show raised hand. Is it A, you consider it as retinoblastoma? Who will raise the hands? Retinoblastoma A? None? Action, please. Retinoblastoma? ما اقتنعتوا؟ B, is it retinoblastoma? Okay. So no much of action. So yes, right is the retinoblastoma and left is an astrocytoma. So it's really confusing, and it's really difficult without experience to know and differentiate which one is which. Again, which one is retinoblastoma? This is a leukocoria, the commonest presentation. So which one is retinoblastoma? Are they all retinoblastoma? Unfortunately, they are not. One is fever, one is Coats, and one is retinoblastoma. So again, the mimickers, they could be clinical and tumor presenting with a mass that confusing us as a retinoblastoma, or the symptoms. The patient present with leukocoria and abnormal red reflex that confuse us or let us think that this patient, we are dealing with a retinoblastoma. So from the shields, she had a a big list differentiating listing the retinoblastoma mimickers in groups like hereditary conditions, development anomalies, inflammatory disorders, and tumors, and miscellaneous. And I will not read the slides, it's in the book there, you can go and look at it. But the important thing is this list, it doesn't reflect the commonest or the frequent mimickers. And in a study done there are different case reports of mimickers in the literature, but this is one of the big cohort study that they studied 2,775 patients with retinoblastoma, and they found that 22% are simulating lesions. And this is the table that shows you the frequency of different diagnoses, and you can see top on the list the Coats disease. So Coats disease account of 40% of these 600 patients. So it's really almost more than 1/3 patient are Coats disease, followed by persistent fetal vasculature, or what we used to call it PHPV. So from now on, I'm going to present cases that are cases of RB mimickers, and we might talk about some of these: Coats disease, PHPV, coloboma, morning glory, endophthalmitis, retinal astrocytoma, medullary epithelioma, vitreous hemorrhage, and juvenile xanthogranuloma, and trauma. I might not discuss some of them, but this is are from our list that a patient came to rule out retinoblastoma. And remember that some patients are referred as retinoblastoma and turned out not retinoblastoma, so it's vice versa. So we'll start with the great mimickers, the Coats disease. Sorry, there's some misarrangement. Anyway, we start with the cases of Coats disease, and this is from our registry as well. It's a 14-month-old baby boy. He's a product of normal spontaneous vaginal delivery and full term. He presented with leukocoria for 1 month, seen in private clinic, and was referred as leukocoria to rule out retinoblastoma or retinal detachment. On examination under anesthesia, it was showed that he has a clear media. Dilated fundus exam showed total thickened retinal detachment with prominent blood vessels. Some are with telangiectasia. So, and the B scan shows vitreous opacity 360 degrees, total RD, and mild subretinal opacities. So this is the B scan showing the total retinal detachment. And this is the EUA, and you can see here his right normal fundus, and then this is the presentation and fluorescein angio, and you can see the dilated vessels and telangiectatic blood vessels. This is confusing because there's a white mass, and you can see also very important point that Coats disease has a dilated blood vessels, and this is very important to know and to keep in mind when you see Coats disease, because these dilated blood vessels usually in Coats disease are irregular, and they are not a smooth dilation. No, there are irregularity, and the part are thickened and then followed by a thin part. So Coats disease is an idiopathic condition, which it's a congenital, presented with congenital retinal telangiectasia. As you know, it's a unilateral disease and commonly in male. It presents with infraretinal and subretinal exudation, with retinal detachment, and this retinal detachment can stimulate or mimic the exophytic pattern variant of retinoblastoma. So as I show in the previous picture, it shows a bulb, dilated telangiectatic blood vessels, and very important, the blood vessels, they cross over the mass, but they don't dip in like in retinoblastoma. So this is very important take-home message. So again, when patient presented with leukocoria, it tends to be white in retinoblastoma, but we call it xanthocoria, as you can obviously appreciate the yellow tinge of the red reflex. So So here also, on your right hand, you can see a retinoblastoma, in your left hand, and you can see how the blood vessels, they vanish, they dip into the tumor, while here in Coast disease, they just cross over the retina. This is a recent publication in 2020, published in Journal of Epidemiology from our institute, and we did study on 7 inoculated globes for Coast disease. And you might think that this is a large number for inoculation for Coast disease, but they usually are advanced cases, and they are, by imaging and other clinical findings, there are still a possibility of retinoblastoma, so we decide to go for inoculation as this is a non-salvageable eye. And as you can see in the conclusion, we found that we have here in the Saudi Arabia a higher tendency to have an advanced stages of Coast disease. So, this is the initial slides that I presented, and we'll talk about one patient. He's a 5-month-old, referred from outside PKH with retinal mass to rule out retinoblastoma. This case, actually, this child presented with history of seizure, and he was investigated, and they found that he has a brain and heart valve lesions, and he has also multiple depigmented skin lesion, the classic Ashleaf maculae. And he was actually diagnosed with tuberous sclerosis by the pediatrician, and he was referred to rule out any retinal mass. So it's the opposite. But I want you to keep in your mind that you might receive the patient initially as retinal mass. So you take a patient as a whole and you look for other. History is very important. So history of seizure triggered the diagnosis of tuberous sclerosis. So actually this was a little bit also confusing if you receive it as an initial case without a diagnosis, because the ultrasound showed the calcification, showed a mass with calcification, so immediately you will think of retinoblastoma. So this is the fundus examination of the right eye, and you can see in the right eye multiple. This is again just to compare. I didn't put the right eye, so this is the left eye with the mass, and you can see multiple hypopigmented. This is the normal right eye. It's actually not normal. It has multiple small spots of hypopigmented, and this is again to remind you with the dipping blood vessels in the tumor, while here you see the blood vessels are crossing underneath this mass. So tuberous sclerosis is often associated with retinal astrocytic hamartoma. It has a variety of ocular, cutaneous, neurological, systemic manifestation. It might present with low-grade intracranial paraventricular astrocytoma, and I think this is the cause of the seizures. He presented with cutaneous angiofibromas, depigmented cutaneous maculae, cardiac rhabdomyomas, renal angiolipoma, and other hamartomas. So remember, retinocytoma, retinal astrocytoma can be classified from birth. So you can have a child, since birth he has a retinal mass and calcification. So be alerted that this is, you had to put top on the list retinoblastoma, but keep in mind that it could be an astrocytoma. Also, the calcification in astrocytoma used to be glistening, while in retinoblastoma chalky white. So the fluorescent angio, this is not the case. This is from the Shields books. It shows the hypodense hypofluorescence, and you can see that the blood vessels seem bypass and not dipping into the retinoblastoma. I will leave this to Dr. Saad at the end to comment. Actually, OCT is a very important tool in astrocytoma because it shows the classical mouth-eaten lesions with cavitation, reflecting the cavitation. So this OCT is very important. Our patient, actually, we plan to put him under, to give him examination under anesthesia, to do OCT and other investigations, but he didn't show up for his EUA. So another case of different entity. This is a 7-week-old boy, product of a C-section, full term, with positive consanguinity. He was referred from Najran to rule out RB. So what do you think this patient presented with? leukocoria. So as I mentioned earlier, this is not a challenging diagnostic issue because this is almost everybody will say this is coloboma, but the issue was in the presentation, the leukocoria presentation. And just to have a clue that in coloboma they have a well-demarcated edges. So coloboma is essentially a congenital closure defect in the optic fissure, and it usually, as everybody knows, located inferiorly in the nasal quadrant. The incidence is very low, it's 0.7 in 10 birth, and typically colobomas involve all the structure that related to the optic fissure. And coloboma of the choroid can be associated with different syndromes, and also it's accomplished with thin sclera. So again, just to manifest, just to stress on this point that they present with leukocoria. Coloboma, they present with leukocoria. So another case, we move to another entity, is a patient, a 4-month-old boy, product of C-section full term. He was admitted in NICU for 1 week due to hypoxia. So as if you remember the list, ROP is also in the differential diagnosis of retinoblastoma, but this is not the case here. So he presented with ET and leukocoria, and he was diagnosed outside as cataract and retinal detachment, referred to KKH to rule out for management. And then on examination we found that the right eye is smaller than the left eye, and he has a clear lens, there's no cataract, but he has a retrolenticular whitish opacity. And the fundus we were not able to examine the fundus. MRI, we done the MRI, and it shows, confirmed that the right eye is smaller, and it has a detached retina. And this is the clinical presentation, and you can see that this is a retrolental mass, and if you can imagine, it's dipping into the center, and this is the ultrasound, and this is the right eye, normal right eye. So this is a case of PHPV, or persistent hyperplastic, vascular hyperplastic tissue. So this is a 3-year-old boy. This is another case of similar condition. He had no NICU admission, and he was referred from Jasan to rule out retinoblastoma. So on examination, his fundus exam shows a whitish lesion with retinal detachment, not involving the macula. And the B scan showed lesion detected superior temporal at the periphery with calcification. So again, this is the important point here. On examination, it was obvious that this patient has PHPV with the total retinal detachment, and this is I'm showing here the ultrasound, which is also confusing because it shows calcification, and this is the clinical presentation, and this is the cause of the leukocoria, and this is the fluorescent angio showing the total RD. So, persistent hyperplastic primary vitreous, or what we call it newly persistent fetal vasculature. How you can differentiate it from retinoblastoma at present at birth in microphthalmic eye. So it's very odd to have a microphthalmic eye and a retinoblastoma. So when you have a small globe, you think of PHPV. And it's almost unilateral and non-familial. So you will not have it in a bilateral or with family history. And it's a wide range. It can range from mild form to severe form. So the severe form, this is when we are confused with retinoblastoma because of the retinal detachment. So one important clinical point is you have, this is from the Shields again, it has elongated, this is the retrolental mass, and it has the elongated ciliary processes because of the stretching of the ciliary processes attached to this retrolental mass, which is almost never seen in retinoblastoma. So, is this a retinoblastoma? What? Maybe somebody's saying it could be. So I will end up with this important case and this important message. I didn't put a lot of history on that, but this is really confusing. When you see, most of us will say this is a retinoblastoma. And this patient is a 6-year-old girl, medically free. She presented with leukocoria to the private hospital, and then they diagnosed her with endophthalmitis, and she received they did a vitreous tap, and she received intravitreal injection. And the B scan showed dense vitreous opacity with highly reflectile surface and open funnel-shaped retinal detachment. So it was really confusing, but when we did inoculation, when we did the examination under anesthesia with the expert, so this is a retinoblastoma, and patient ended with inoculation, and the pathology proved that this is a retinoblastoma. So this is really an important take-home message, because you should not open an eye when you suspect a retinoblastoma. And unfortunately, I don't want to add any pathology photos to this lecture, but the pathology showed the disruption of the conjunctiva and the sclera where the injection was given, and actually there was a seeding, a ball of tumor cells at the surface of the conjunctiva at the site of the injection, and there is iris and angle invasion, which is there's no choroidal invasion, which is very unusual, and this is hopefully secondary to the injection that was given. Usually anterior chamber and anterior angle and iris invasion, ciliary body invasion, usually you don't see it solar, you see it with the posterior invasion. So please be careful in the children. I think this is also presented with little bit elder age. She was 7 years old, and this adds to the confusion. So please, when you suspect any retinoblastoma or you have any doubt, don't touch the patient, don't open the globe, and refer to the experts. And this is the last slide. Thank you.
Thank you, Dr. Azza, for this informative review and lecture. So I open the floor for discussion or questions.
Thank you, Dr. Azza, for your nice presentation. I think it's a very concise and up to the point, and actually it shows a very important subject and how to have misdiagnosis in this very important subject. Just one question about the two cases. The astrocytoma, what makes it mimic retinoblastoma?
The mass in the retina.
The mass and the result, Coats disease?
Yeah, there's a retina, that's what I mentioned. If you receive this patient initially without the diagnosis, this patient actually was diagnosed with tuberous sclerosis. And then he was sent to the clinic to rule out retinal masses because they are expecting. But my point, if you receive this patient initially, the ophthalmologist was the first to see this patient, and you have a retinal mass, you should explore and take more history. And seizure history is very triggering to reach the diagnosis. But as a mass, it's really confusing.
In Coats disease, the blood vessels, I think it's very important to see that it's in retinoblastoma, it's slipping in the lesion.
Yes.
Do you have an explanation why here it's slipping while in Coats not?
Because it's a tumor that depends on the vascularity, and it feeds on blood, and it needs blood to grow. It's part of the vasculature, part of the consistency of the tumor. That's what we see by histopathology as well.
The other point that's regarding the important message, endophthalmitis has a lot of other signs rather than just leukocoria. So I think it's not if you know the signs of endophthalmitis, you will not have difficulty or confusion in diagnosing retinoblastoma. I think it's very important to be careful when you have anything. You have to presume the most serious diagnosis rather than just to see. Thank you very much.
Thank you for the comments. Sorry, please.
Bismillah. Thank you very much, Dr. Azza, for a very fruitful, rich presentation. I would like just to shed light on what Professor Mubarak mentioned regarding how could we miss retinoblastoma. First, most of cases, sometimes the physician is underestimating the diagnosis. Second, they are not exposed to see a large number of retinoblastoma. We have maybe a series of maybe 10 or 12 patients who were operated by consultants as non-retinoblastoma. We saw cases treated as endogenous endophthalmitis. They didn't examine the other eye, baby just born, and they noticed that there is cellulitis or endophthalmitis. They went in, AC tab, vitreous tab, the cytology came as a malignancy. We saw cases treated as COATS, discharged from the system as non-salvageable eye, blind eye. Patient presented few months with orbit extension metastasis. We saw cases operated by glaucoma people. We saw cases operated by retina surgeon. We saw cases operated and neglected even by pediatric ophthalmology. Recently, we saw one patient. He's almost maybe 2 years. Seen by 1 year. She's seen by a pediatric ophthalmologist in Riyadh. Assured them that she was seen at 6 months, and assured them that it's just infantile esotropia. No fundus examination carried. Family, they decided to take a second opinion from another pediatric ophthalmologist. He copied the same diagnosis. They didn't do fundus exam. At 1 year, patient go back to the primary physician with the leukocoria is clear, and everybody should identify that this is. Patient came to us, unfortunately, she has very advanced disease. We ended with systemic chemotherapy. Family elect to go abroad. Patient now is still on treatment. The visual outcome is very guarded. The life of the patient, we don't know what's the prognosis. For this reason, all patients with leukocoria is RB until proven otherwise. No intravitreal, no intraocular surgery should be done on those patients with leukocoria, except if it's seen by expert people and identified this is not retinoblastoma. We saw cases, we stopped the case on the table, not to do a drainage for Coats disease because it's an RB. And this happening by senior staff because they are not exposed to serious retinoblastoma cases. We saw cases, as mentioned by Dr. Azza, treated as endophthalmitis. We saw cases treated as endogenous, fungal endophthalmitis. For this reason, we're going to look at all these cases and hopefully we could report them and publish them. But this is not, a unique thing. It's happening all over the world. I'd like to thank you, Azza, for this nice presentation. We are trying to maintain such presentation for the residents annually to make them always memorizing that there is something dangerous and these cases should not be missed. I saw one patient maybe a few years ago seen at ER at KKH, diagnosed as Coats disease, referred to the pediatric ophthalmologist, seen by the pediatric ophthalmologist. He didn't work the patient at all. Since the diagnosis was made in the IR as Coats, he copied the diagnosis, discharged the patient from the system. Patient came to us after 7 months with spine metastasis, brain metastasis, everything. For this reason, don't be overconfident with leukocoria cases. Take second opinion. Will not cause a harm. We are available, and we could reach the patient within a few minutes to a few days or few hours. This message, as mentioned by Dr. Azza, for all those junior staff who will be a senior in the future, not to miss these cases. Thank you very much, Chancellor.
Thank you very much for your valuable remarks.
Thank you very much for the nice presentation, and thank you for reminding us about retinoblastoma. 2 questions. First, retinoblastoma can be presented with endophthalmitis without seeing a mass or something. Yes, so if we have endophthalmitis, we have to suspect it if we don't have a cause like a trauma or a surgery. This is the first. Second question, is retinoblastoma associated with a gene, a non-gene, and if we can do like genetic counseling or something for families with retinoblastoma history? Was it working?
No, it wasn't.
Okay.
The answer of your first question, why endophthalmitis might be confused with
No,
retinoblastoma.
can be presented, retinoblastoma can be presented with like pictures of endophthalmitis.
Yes, that's what I'm explaining. Because when you have a mass that is highly necrotic, it will be very confusing with by imaging, by even by examination. So this is, yes, it might be.
So we have suspect if we don't have a cause for
Yes,
endophthalmitis, no
especially
trauma, no surgery.
in this age group. And
It's
regarding
a
the gene, it's yes, it's related to 13q to the 13 gene, but it's difficult and it's not cost effective to do a genetic study for every patient that you are suspecting retinoblastoma. I think Dr. Mani left, but she might. Dr. Saad, you have a comment on that?
Just to know, this is germline or somatic. But it will not help you in the diagnosis. Just to know what's the origin of retinoblastoma. This is good for the family, for the future, and for the day. But we never diagnose retinoblastoma with genetic. Regarding what first question Dr. Azza has answered, the endophthalmitis in pediatric age group, infantile, especially first year, as you remember, the immune system in pediatric is not mature. If you have a child with vitreous pathology, don't put your mind this is uveitis or endophthalmitis as the first line. Put in your mind this is retinoblastoma number 1 and number 2 retinoblastoma until number 10. Then think about endogenous endophthalmitis. You know, in my experience, the most difficult diagnosis to differentiate between retinoblastoma is the endogenous endophthalmitis. Because sometimes it's difficult. Because endogenous and pediatric infantile, the ACU usually quiet, become with quite eye, only vitreous opacity. Sometimes the patient is neglected in ICU. Patient come quiet eyes, both eyes, especially we are working in general hospital in the university. Both eyes are quiet, the vitreous is white, you don't see anything behind. Sometimes the B-scan cannot pick up the mass, so it's tricky. So the endogenous endophthalmitis is sometimes difficult to differentiate from retinoblastoma. And as Dr. Saleh mentioned, he's the expert and the father of retinoblastoma in the country. So many times the retinoblastoma is confusing diagnosis. You know, there is one case, even the literature, before 2000 publication, 5% of the nucleated globe for retinoblastoma tend to be not retinoblastoma. But if you have a risk and the eye is not salvageable, go ahead and do enucleation. There is a chance that it tend to be retinoblastoma. So if you get a message from this front round or lecture, just put retinoblastoma as in your mind always. Any case, especially pediatric age group, any case with vitreous pathology, don't put uveitis at first. Make sure this is not retinoblastoma. And sometimes that you cannot see the mass. And many people, they think the calcification is pathognomonic. It is not. Many times we see retinoblastoma without calcification. And the old teaching, you should do CT scan, is now obsolete. Don't do CT scan for retinoblastoma. Because if it is germline, you trigger the second cancer by your radiation, so don't do it. Except in rare occasions. So the retinoblastoma diagnosis, always by eye. If you could see the mass, then the diagnosis will be easy. But the problem sometimes you cannot see it, either because of severe vitreous opacity, either the seeding or the retina is completely detached, you cannot see the mass. This is the conclusion, most of the time. If you could not see the mass, most time the diagnosis will not be easy. And we depend on the ancillary testing and other way of testing. But if you have a child that there is a possibility, this could be retinoblastoma, don't hesitate, don't put a diagnosis. Do EUA. Most of the time the clinic exam is difficult for pediatric age group. The child is uncooperative, he cannot do proper exam. So don't hesitate to take him for EUA. Any questions?
Just would like to add one. Is it possible to have patient with the primary diagnosis of retinoblastoma? I mean, let's say that patient with BHPV or retinopathy prematurity and retinoblastoma. According to our series, yes, we have one patient with bilateral premature retinopathy prematurity and ended to have bilateral retinoblastoma. Ended with enucleation, and I think it's published as a case report. Also in the literature, you will find some cases being reported as BHPV and retinoblastoma. For this reason, sometimes the primary diagnosis may misguide you to make the correct diagnosis, or coincident, you'll find that there is retinoblastoma in the same patient with primary diagnosis.
Go ahead.
Thank you, Dr. Azza, for this excellent presentation. I have a question. If we have, like you mentioned, some of the patients who have coats, they ended with inoculation. If there is high suspicion this is a coats, okay, but still we are not sure, is there a possibility, or can we do like fine needle aspiration under good technique with cryo at the end, just to confirm this is coats or retinoblastoma, and then at the end we save the patient from inoculation.
Thank you for your question. Sometimes, as Dr. Saad mentioned, it's really difficult to differentiate between these two cases. And opening the eye is not advisable by any means to enter the eye when you are suspecting retinoblastoma. Though we have the patient with retinoblastoma, and we do intravitreal injection under, as you mentioned, precautions and cryotherapy to the site. But if you are not the expert and you are not expecting retinoblastoma and you didn't do this procedure, then we ended up with a disaster. So as Dr. Saleh Misfer said, always you ask for a consultation. You ask somebody else before you open this eye by any means. We have a case that we were highly suspicious that it is Coats disease, and we did drainage, and yes, we could see the foamy histocytes in the subretinal fluid. But as I said, it's not always it's not advisable to do that. Plus, usually those cases were inoculated. We have other supporting evidence, like by imaging, that they cannot totally rule out retinoblastoma. And this is a non-salvageable eye, non-seeing eye, and he might end up probably by a few years with a thicycle eye. So this is usually we discuss the patient. This is there's a remote possibility that this is a retinoblastoma. So we go up and elect to do inoculation for both confirmation and to save the life if it's turned out to be retinoblastoma. There was one case I remember with Dr. Misfer that it was really, really very confusing between retinoblastoma. And each time we examine the patient, we go in, we say Coats. We go out, and then we think it's no. We are very we are very we are very worried that it is a retinoblastoma. So it's really not an easy decision. Maybe Dr. Saleh would like to.
Regarding the question of Abdullah, I did an operation for patients where there is no masses at all, empty vitreous. Totally, there is no mass at all, and we ended with inoculating the patient. We faced difficulty to confirm is it retinoblastoma or not. And I didn't know if Azza remember, we sent it to your pathologist friend, what is it? Right, where he confirmed it. He's found some retinoblastoma in the ciliary body. For this patient, sometimes after when they develop cellulitis-like picture, massive infarction will happen within the tumor, and this infarction will end with all these cells being necrotic, and you will not find any masses. If we ignore this patient, this patient, I may go and do fine needle aspiration for the clear cornea and base of the iris to avoid the lens, but in the same time, I may not obtain anything. For this reason, if the visual acuity is poor and the prognosis is poor, we discuss it thoroughly with the family, that there is a process, a mass. We may end it with benign process or malignant process. If it's a benign, it's a good news for both of us. If it's a malignant, we have to go through further treatment. For this reason, enucleating a blind or unsalvageable globe with masquerading presentation, I think it is very safe and it is allergic.
Any questions? questions or
May I
comments?
comment?
Go ahead, Professor.
So, for pediatric retina surgeons, there are rules that you should follow. The first rule is that you should rule out retinoblastoma by a retinoblastoma specialist. The second rule is rule out retinoblastoma by a retinoblastoma specialist. The third rule is the same. So, always we depend on Dr. Saleh to help us in this. One thing that is special to our region that may be a mimicker is FRAM or Ramus VBS. We have seen cases that present very early in life with exudative detachment and total exudative detachment in one eye. And if you look carefully to the other eye, you will find the persistent remnant thyroidal artery behind the lens and beating of major trunk vessels. So this is something that is here in this country and in the Gulf region, not elsewhere.
Thank you.
Thank you, Dr. Suleiman. Just to alert the retinal surgeons, I came across two cases. One operated at Kekish and one operated at King Abdulaziz University Hospital as retinal detachment, and they turned out to be retinoblastoma. And unfortunately, the surgeon non-operable and they closed. The third case was a family who from Bahrain. They went to Germany. They did the same. They did retinal surgery. Well, this season, as Dr. Suleiman said, rule out retinoblastoma 3 times. I think it is right.